Innovations in Musculoskeletal Care.
Hi, good morning. So I'm Saverio Bianco.
And I'm Neil.
And so I'm working as a higher specialist trainee at our local hospital, Mater Dei Hospital, in orthopedics and trauma surgery. And you're...
I'm the director of the Innovation Center at Cooper. It's a health system in southern New Jersey. It's the largest health system there, about 800 beds, 2 million patient visits a year. And we do the patenting, licensing, assist startup companies, and also act as the bridge between companies that want to do clinical validation and the physicians in our system.
So today we're going to cover, obviously, an innovation in musculoskeletal care. We're going to be discussing what happens locally in Malta and in Europe. And obviously, Dr. Lemon will kindly give us some info of what he's doing back in the States, right?
Absolutely.
Yeah. So
some of the things that we're working on is we have a focus in line with this panel with orthopedics and pain management, in that we are seeing the optimal treatment for many of these disorders span across orthopedics, pain management, psychiatry, and some of the other spaces. And there's also new, different technologies or repurposing of older technologies, which look like they're quite promising in the treatment. An example of which is use and resurgence of psychedelics in the psychiatry space, the effect of cognitive behavioral therapy when it comes to treating the psychological issues associated with pain and pain management.
And that's obviously the preoperative, the perioperative, and the postoperative period, I suppose.
Absolutely.
So, as in Malta right now, obviously we treat pain most of the time acutely. So, once the patient is in pain, obviously we'll give him something for the pain. But obviously there are preemptive measures, especially in the perioperative period. So we tend to recently, obviously, rather than going for a general anesthetic, we're considering obviously more regional blocks and spinal blocks, which obviously will alleviate the symptoms post-operatively. Regarding on the cognitive point of view and the psychological point of view, I think we're not there yet. I don't know what kind of what you can suggest and advise.
Yeah, at Cooper, there's a good amount of collaboration between psychiatry and pain management. We're trying to put in a new institute on neuromodulation, focused on the interface of substance abuse disorder, mental health issues, and pain management. But pain seems to be central to many of those other issues. Also in Camden, New Jersey, where our main hospital is located, it's the epicenter of one of the epicenters of the opioid crisis.
So you're really, as in, focusing on the social determinants of health, and obviously, which is a good thing after all, having taken care of the preconceived ideas of the patients prior to an operation, prior to any burden of disease after all. But so the psychiatrists are on board before the procedure, or how does it?
Some before. We're still preliminary research between the two, some of it using kind of ketamine trials, cognitive behavioral therapy, and looking at pain scores associated. So if there's diagnosis of, like, say, pain or depression, which often is the case, to make sure that those specialists are talking to each other. And we also want to tease out where maybe the cognitive behavioral therapy is having a positive impact on the pain perception, and vice versa. If you're looking at alternatives, like you were saying, to pain treatment, it focuses on the precision, treating the pain where it is instead of just necessarily giving a systemic opioid, or alternatives through like stimulation. And we're starting to look at, is it possible that some of these psychotropic substances might also have an effect on the pain scores, and how can we better measure pain other than just self-report? I know pain's very complicated, but we're investigating different tools that'll be a little bit more quantitative.
So you're taking really the biopsychosocial aspect of a patient, really. The problem, I think, in Europe is the fact that we're very strict with guidelines. In a way, we follow the World Health Organization guidelines, so the WHO and analgesic letter. So obviously, we always titrate accordingly. However, I think focusing and putting our efforts into these nerve modulation, for example. In Malta, we have this pain team, which is led really by anesthetists and anesthesiologists. They do quite a good job. So, for example, recently for chronic lower back pain, they introduced this radio frequency, pulse radio frequency, which obviously stimulates nerve roots. So they stun the nerve, and obviously, eventually, that will promote less nerve irritation and obviously a better, less symptoms for the patient.
And how are you finding quantifying the results of that treatment?
As obviously we audit ourselves. I suppose the anesthetic department audits itself, and there are quite a lot of patients because we see them first at orthopedics, then at the orthopedic clinic, then we refer them to our colleagues from the anesthetic department, and then they come back to us. Most of them do well. Most of them, obviously, you always have those who eventually will need a surgical intervention to alleviate the symptoms. However, as I said, so I think rather than being rigid with ourselves and just following guidelines, I think we need to obviously look into these innovative ideas, and I don't know.
I know in the United States it's a little bit challenging in that these treatments typically for adoption in clinical practice need reimbursement codes. So you are somewhat tied outside of the research setting to what you can get reimbursed from, Medicaid. There's other patient groups like the veterans, the VA, that have a broader range of coverages available for treating pain, and we're really investigating that to leverage that as part of the research to allow for multi-format treatments. So to have the CBT covered with, say, a nerve block covered with...
So it's a multimodal thing in a way.
Yeah, and in the US, the Veterans Affairs, some of those applications help maybe provide proof of concept, and then we can go to Medicaid and we can see what the coverage is. One of the difficulties, though, is some of the more promising new treatments are not necessarily from prescribed medications. So if you're looking at like cannabidiol, there's some potential for that use in lower back pain. So what's the formulation? There's a lot of different potential ways it could be applied.
And rather than, obviously cannabis oil, and then we've been trying them out in Malta, and obviously with the new legislation, I think more practitioners, more doctors, healthcare professionals will try to gain access to that. However, I think we should owe it and obviously continue to encourage maybe a multidisciplinary team approach in a way that even physiotherapists, I think there is a point that they'll lead on obviously the rehabilitation, which is part of the obviously treating the pain after all, after the procedure, having a good rehabilitation thing. So encouraging more technological let's say, aids to our colleagues, like physiotherapists, like the occupational therapists. I think that, in a way, would further improve the patient's outcome and decrease morbidity after all.
Absolutely, and there's a great public role for these evidence-based solutions, because I think intuitively as a provider, you know that the treatments have to come from more than one focus, but you need those treatments to be evidence-based. So the public helping to pay to look at how to treat pain in a more progressive way is absolutely essential, because before it goes into clinical practice, you need the evidence.
And yes, just sticking to just medication. Even for the patient, you're not giving him, how do you say it? an outlook on his own health after all, and on his own benefits. Obviously, pushing him with exercises, and I think it's better than just going for an opioid alternative and just sticking to that. After all, opioids have their own side effects.
Absolutely.
And that obviously will ultimately hinder certain rehabilitation as well.
Well, I know from my perspective, because I run an innovation office, so some people say if you're a hammer, everything looks like a nail.
Yeah.
So all the solutions I see look like some technologies that I come in, and be it like a digital health technology to better track and monitor pain, to provide that feedback.
Yeah.
There's new sensing technology, which may disentangle the physiological from the psychological to help us get a better sense. New imaging technologies that have kind of seem to have been in the work for a couple decades, like infrared imaging, fMRI, is a great
functional
technology,
MRI, yes.
It's expensive.
It's that's the problem with.
And
you cannot cater for the whole population after all.
I think the feedback's important to show like physiological self-reports, and very curious in some of these different cognitive behavioral therapies tied with medication, and kind of disentangling the physiological aspect of pain from the psychological
aspect. Okay. You mentioned before when we were discussing even when it comes to neuropathic pain, you mentioned that there have been advances as well with.
Yeah, and it's crazy, like diabetic neuropathy, and like with diet and genetic predisposition, it's a huge issue in North America. You were mentioning it's an issue.
It's an issue in Malta. Unfortunately, we're laden with diabetes in Malta. That's in our genetic pool. So yes, it's one of the burdens of disease of Malta. And you mentioned that Bluetooth thing is.
So I know one of the technologies, because previous to joining Cooper a year and a half ago, I was at the University of Pennsylvania for 6 years, and there are a lot of brain-machine interface technologies work. One of them was to have sensors on the sole of the foot that were connected by Bluetooth so that you could reanimate the limbs. Surprisingly, amputation of feet and things is still a very common procedure, both in Malta and in the United States.
Yes.
And this was a technological solution to increase vascular activity in the extremities. But my personal thinking too is, before it gets to that point, is there a way to engage with your primary care physician and to have some monitoring so you don't get to that point?
Before that. As in, interestingly as well, one of the poster presentations here mentioned maybe we can consider virtual reality in the perioperative period.
Absolutely.
Very good poster presentation. So they're getting patients rather than using certain sedative techniques, whether it's gaseous form or intravenous form. They'll put on a headset on, and they'll give you this ambiance, a calmer environment, let's say, because everyone is anxious prior to a procedure, and it seems that it helps a lot. So
this is an area that's very close to me. This augmented reality, virtual reality. At Cooper, we have a proposal to set up an innovation lab with an AR/VR focus. Also looking at companies that have sensor-based artificial intelligence applications, where we can look at immersive experiences. Some of those, like the use of psychotropic medication, so there's been a lot of resurgence in the interest in psilocybin, MDMA, having the right set and setting for the cognitive behavioral therapy to go with the neuromodulation. And I think AR could have a great effect there in both treating for treatment-resistant depression, post-traumatic stress disorder, pain potentially as well directly.
You mentioned that transcranial nerve modulation, sometimes it can be used as well.
TMS, there seems to be growing evidence independently for a lot of these modalities. TMS may be a little bit more for migraine, central pain than for peripheral nerve pain. But given the opportunities with TMS, some of the advances with alternative pharmacology, and I believe the firm needs to also rewire the brain through cognitive behavioral work. that there's a great opportunity to use these different tools working across disciplines in medicine to provide better solutions for patients. And that's what we're trying to do at Cooper with our Nimbus initiative. We have a proposal into leadership to expand our research and clinical practice in neuromodulatory space and to work across providers and across technologies to do that. The question is, once you get the evidence, can it all be paid for, and is it, but we're also trying to work on that.
Analysis of it all.
But we hired a person to come in and consult for us that has a background in business development and insurance.
Okay.
So I'm like, okay, help us run the numbers, create a table showing the different treatments, the different payer groups, and then hopefully a good portion of those are currently in the green. We can start with them and then work our way out.
Okay. I think we spoke a lot. I don't know whether you have any questions from your part. Is there something to add, as in from my point of view?
I want to mention that this is my first visit to Malta. I did my graduate work in Germany. I lived in Germany. First time in Malta. And this has been an absolutely fantastic conference and excellent hospitality. So
after
really
all,
pleased.
we thank Dylan Attard, obviously, for giving us the opportunity and hosting this. So quite a venue. And it's been great.
They've done a fantastic job.
Yeah. Any questions for your part? Good.
All right, I guess we'll let the next speakers come on.
Yes.
Thank you, Severio.
It's been a pleasure, Dr. Lemon.